Okay, so when you think about older adults, what image pops into your head? Is it maybe, the usual stereotypes, one frail, maybe forgetful, kind of stuck in their ways? Well, if that's your picture, get ready. This deep dive is going to challenge that completely. We'll show you a reality that's way richer, more complex, and honestly, more inspiring. Welcome to the deep dive. We cut through the noise to get you the knowledge you need, straight from the source. Today, we're cracking open the Older Adults chapter. It's from that cornerstone text, Fundamentals of Nursing, 11th edition by Potter, Perry, Stockert, and Hall.
Exactly. And our mission today, pretty straightforward. We want to pull out the absolute must-know insights from this chapter. We're going to distill those crucial patient care principles, help you sharpen your clinical decision-making, look at safety protocols, really unpack the nursing theory behind great gerontological care, and of course, touch on ethics, evidence-based practice, all tailored for older adults. We'll show how it all applies in the real world, hospital, community settings, even home care.
Yeah, and don't worry about getting bogged down in jargon. We'll break down any complex medical terms. If there are charts or procedures in the book, we'll describe them clearly so you get the picture. We'll weave in critical thinking prompts too. The goal is simple. You walk away not just knowing this stuff, but ready to use it. We'll definitely link it to NCLEX competencies and best practices. So let's get started. Let's dig in. First things first, let's tackle some of those myths head on. The chapter does this right away. It challenges that pervasive idea that hitting 65 automatically means you're old, sick, disabled, or, losing your memory. The truth, many older adults actually see themselves as middle-aged, well into their 70s. And the chronological age often has very little bearing on how they actually experience aging. Every single older adult is unique. That's takeaway number one, right? Got to see the individual.
Absolutely. That focus on the individual is critical. And it leads us straight into a really fundamental concept. Ageism. It's basically discrimination just based on age, like racism, like sexism, same thing. And this chapter shows how damaging those negative stereotypes can be. They can really undermine self-confidence, limit access to care, and honestly just distort how we as caregivers see that person. Our role as nurses here is huge. We have to actively promote a positive view of aging, respect older adults as independent, dignified people, and crucially, involve them in their care decisions, always.
It's also pretty striking how much the demographics are changing fast. The number of older adults in the U.S., it's set to nearly double by 2060. We're talking like 95 million people. And that population is becoming way more racially and ethnically diverse, which for us means culturally sensitive care, linguistically appropriate care that's not just nice to have, it's essential.
Yeah, that increasing diversity really underscores the huge variability among older adults. It's immense. You see this incredible range in their health, physiological, cognitive, psychosocial, and their functional abilities too. Most older adults are actually active, living independently. Think about this. Only about 3.1% live in institutions like nursing homes. Tiny percentage. And many stay functionally independent even with chronic diseases. So we can't just assume decline based on age or a diagnosis. Never.
Okay, so given all that variability, what are some common developmental hurdles or tasks older adults face? The chapter lists a few key ones in box 14.1. We often focus on the physical stuff, but the psychosocial side is just as important, isn't it?
Definitely. Think about adjusting to health changes, retirement, losing loved ones, spouses, friends.
Redefining family relationships, accepting themselves as aging, maintaining living arrangements.
These aren't just items on a checklist. They're deep emotional journeys.
And the nursing implication. We need to be really sensitive to these potential losses and be ready to offer genuine support.
And that sensitivity, that's really the core of gerontological nursing. The goal, like the text says, is care that aligns with goals mutually set by the older adult, their family, the whole healthcare team. And that starts with a really comprehensive assessment, not just looking for problems, but identifying strengths, limitations, resources, getting that baseline of their health and functional status.
Right. So given how unique everyone is,
Yeah.
what are some of the maybe surprising challenges nurses run into when trying to do that assessment, trying to get the full picture?
That's a great question, because assessing older adults, it often takes longer. You're dealing with a much longer life history, potentially more complex medical background.
Right, makes sense.
And you might need to factor in rest periods, or even break the assessment into a couple of sessions if their energy or endurance is lower. And, this is critical, sensory changes can really interfere.
Like vision or hearing.
Exactly. Decreased vision presbyopia, issues with glare, telling colors apart, Or hearing changes like presbycusis, that's the common loss of high-pitched sounds. Or even just, earwax buildup. These things can seriously mess up communication. So the book suggests practical things. Speak clearly, low-pitched voice, face them directly, cut down background noise, make sure they're using their glasses, their hearing aids. Simple stuff, but vital.
Okay, so individuality check, assessment challenges check. But this next point from the book, honestly, it's a bit mind-blowing, maybe even a little scary for a new nurse. It says classic signs of disease are often absent, blunted, or atypical in older adults. What does that actually mean in practice when you're looking at a patient?
This is probably one of the most crucial takeaways for nursing students. It changes everything about how you approach assessment. Picture this. An older patient presents with, say, new incontinence, maybe just a slight temperature elevation, or no fever at all. Your textbook might scream, UTI means burning frequency. But for this patient, it might just be the incontinence, maybe some confusion. That's it. Or take pneumonia. It might show up as confusion, maybe a fast heart rate, fast breathing, but without that classic productive cough or high fever you expect. And maybe the most startling example, a heart attack, an MI. It could look like sudden shortness of breath, anxiety, confusion, completely without that crushing chest pain we're all taught about.
So that demands a whole different level of clinical judgment from us, doesn't it?
Absolutely. It requires you to be a detective.
So how do we get better at spotting these, hidden signs? The chapter introduces something called the SPICES framework, box 14.3, describes it as a key overall assessment tool. It's an acronym. Sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, and skin breakdown. The idea, it seems, is that a change in any one of these areas is a red flag, right? It triggers a deeper look.
Exactly. SPICES is your go-to framework. You'll use it constantly. And the text in box 14.4 gives great setting-specific examples of these altered presentations. Like in the hospital, new confusion in an older patient isn't just getting older. It's a potential medical emergency until proven otherwise. In a nursing center, even a small decline in function could signal a serious new illness. Ambulatory care. Someone reports unusual fatigue. Could be anemia, thyroid issues, and home care. Every fall needs investigation. It might be the only sign of a new problem somewhere else in the body. You have to be vigilant, always looking deeper, no matter where you are.
That's such a key point. It feels like standard textbook presentations just often don't apply. Dehydration is another one, right, where the usual signs might be masked.
Yeah, because of reduced thirst sensation, changes in muscle mass.
And those subtle functional losses, and maybe they're just a bit slower addressing this week, that could actually be the first clue to something bigger, like a thyroid problem or an electrolyte imbalance. Our job is catching those subtle shifts.
Moving on to physiological changes. Table 14.1 gives a great overview of common physiological changes with aging. Super important to remember, these are normal, not disease. But they do make older adults more vulnerable. Take the skin, the integumentary system. It loses elasticity, gets thinner. So what we think of as good hygiene for younger folks, daily hot showers, lots of soap can actually damage older skin. Strips the natural oils.
Huh. Counterintuitive.
Totally. So maybe less frequent bathing, more gentle cleansers, definitely moisturizers. Rethink the whole approach.
And the heart and vascular system. Decreased cardiac output. But the book really stresses this point. Hypertension is not a normal aging change.
Crucial distinction.
Right. Even though it's common, it's a major risk factor for heart failure, stroke. Serious stuff.
The takeaway. We can't just wait for symptoms. We have to be proactive, screening, educating, especially in vulnerable communities with less access to care.
Makes sense. What about other systems?
Well, GI system. Peristalsis slows. Taste and smell can change, which affects nutrition. Musculoskeletal. Muscle mass and bone density decrease, big risk for osteoporosis and falls. Neurological. Reflexes slow, sleep patterns often change. And reproductive and urinary. Hormonal shifts, prostate issues in men are common. Incontinence stress or urge type is common for both men and women, but it always needs assessment. It's not just normal aging. And critically, remember sexuality. Desire, need for intimacy, touch that persists. Our role. Provide privacy, be non-judgmental, offer STI info if appropriate.
Okay, shifting from the purely physiological to functional changes. The text emphasizes how dynamic physical function is. It's not fixed. Decline is often tied directly to illness or disease hitting them. We look at ADLs activities of daily living, bathing, dressing, feeding oneself, and IADLs instrumental activities of daily living like managing money, shopping, using the phone.
Right. And a sudden change in their ability to do these, that's a really sensitive indicator that something new or something worse is going on health-wise. Now, let's talk cognitive changes because there's a huge myth here the text tackles directly. The idea that significant memory loss or cognitive decline is just an expected part of getting older. Total myth. Disorientation, losing language abilities, poor judgment, those are not normal aging. They always signal a need for further investigation.
Which brings us to something that can be really confusing, but it's vital for practice, and definitely for the NCLEX. Distinguishing the three common conditions affecting cognition. Table 14.2 in the chapter lays out delirium, dementia, and depression, side by side. Key differences in things like onset, course, consciousness, attention.
Yeah, let's break those down because telling them apart is so important. First, delirium. Think acute. It comes on suddenly, maybe hours or days, and it's often reversible, usually triggered by something physiological, an infection, maybe electrolyte imbalance, new medication, or even environmental stuff, unfamiliar place, sleep deprivation.
Okay, so it's a medical emergency, basically.
Absolutely. Needs prompt assessment, find the cause, treat the cause. Nurses are key here because we see that rapid onset. Then there's dementia. This is different. Think gradual, progressive, and unfortunately irreversible. Alzheimer's is the most common type. It's a chronic decline. And behaviors you might see, like wandering, that often signals an unmet need, maybe hunger, pain, needing the bathroom, even boredom.
Right. Not just random behavior.
Exactly. The dementia care practice recommendations in box 14.5 really stress person-centered care. Focus on non-drug interventions first, maintain dignity. And third, depression. This one is incredibly common in older adults, but sadly often missed and undertreated. It is not a normal part of aging, let's be clear on that. It can get worse with chronic illness or major losses. Loneliness is a huge factor. And tragically, suicide rates are higher in older adults, particularly older white men.
So screening is crucial.
Absolutely. Using tools like the geriatric depression scale can make a huge difference in catching it early.
Okay, moving beyond the physical and cognitive. Psychosocial changes? This is huge too. Older adults often deal with a lot of loss, right? Retirement, losing social connections, health declines, death of partners, friends.
A heavy burden. And the text even notes how things like childhood disadvantage can echo into older age health outcomes.
So let's dig into some specifics. Retirement. It's not just stopping work, is it?
No, it's a massive life transition. Big role changes. Can lead to loss of identity, social isolation if people aren't prepared. Nurses can really help here, talking about planning for meaningful activities, finding new social connections.
And social isolation itself, what drives that?
Can be lots of things. Sensory loss, not being able to get around easily, cognitive changes, loss of friends or family. Our job is to screen for it, help them connect with community programs, maybe volunteer groups, things like that.
And an area that's often maybe tiptoed around, sexuality, the chapter's pretty direct.
Yeah, it emphasizes that sexual desire, the need for intimacy, warmth, touch. It continues throughout life. It doesn't just switch off at 65. As nurses, our role is simple. Provide privacy, be non-judgmental, offer information on safe practices, STIs if relevant, and honestly, just the power of touch itself, non-sexually, can be incredibly therapeutic, especially for someone feeling isolated.
Then there's housing and environment. The idea of aging in place seems really popular, staying home.
It is, but it requires planning for safety. The text gives practical tips. Grab bars in bathrooms, non-slip surfaces, decluttering pathways.
The lighting.
Crucial. And furniture that's easy to get in and out of provides good support. Even simple design things like using contrasting colors for walls and door frames can help someone with vision changes navigate better.
Okay, let's broaden out to health promotion and maintenance. We have national goals, like from Healthy People 2030, aimed at older adults. But barriers exist, right?
Yeah.
Bad past experiences with healthcare, low health literacy, transport issues, cost.
Definitely. Our role becomes one of empowerment, helping them make informed choices. This includes pushing for those general preventive measures, regular checkups, primary care, dental, vision, hearing, getting the right screenings, mammograms, colonoscopies, bone density, immunizations, flu, shingles, pneumonia, and, of course, healthy lifestyle choices.
And teaching older adults effectively, especially if health literacy is a challenge.
Yeah.
Box 14.6 has specific strategies.
Yes, really practical stuff. First, make sure they're ready to learn. Quiet environment, comfortable. Adapt your materials. Large print, black on white or cream paper is best. Use clear, simple language. Avoid jargon. Use pictures, demos, videos to back up your words. Give them time to process. Don't rush. And the most important part, evaluate understanding using teachback. Ask them to explain it back to you in their own words. That's how you know it landed.
Now thinking about major health concerns. Heart disease, cancer, still leading causes of death.
Right. For heart disease, remember hypertension, the silent killer. Many don't know they have it, so screening is key. For cancer, education on risk factors, knowing warning signs, and getting screened are vital for early detection.
Chronic lung disease like COPD, also huge, which really underscores the impact of smoking.
Massively. The text points out that quitting smoking even after age 50 can cut the risk of premature death by half. Huge benefit, never too late.
We also need to watch for alcohol abuse. Might not look like you expect. Could present as repeated falls, memory issues, confusion.
Good point. And nutrition, we know there are challenges with taste, smell, maybe chewing. But promoting healthy eating, ensuring enough protein, using resources like home-delivered meals, meals on wheels, for instance, that's critical.
And dental care, often overlooked. But bad teeth or ill-fitting dentures can really impact nutrition and health.
Absolutely. And this brings us to exercise. Such a cornerstone. The official guidelines recommend multi-component activities. Balance, aerobic, muscle strengthening. The benefits? Immense. Better function, stronger muscles, healthier bones, stress reduction, even helps protect brain health and cognition.
Safety first, though.
Always. Supportive shoes, stay hydrated, avoid extreme heat or cold, maybe exercise with a buddy, and teach them the warning signs. Stop immediately if you get chest pain, dizziness, significant shortness of breath. Get help.
Okay, out of all the challenges, the chapter singles out one as perhaps the greatest: medication use and polypharmacy.
Yeah, polypharmacy, using multiple medications at the same time, it's incredibly common.
And risky, right?
Very risky. Increases the chance of adverse drug effects dramatically. This is because normal age-related changes affect pharmacokinetics, how the body absorbs, distributes, metabolizes, and excretes drugs. Things just work differently.
So what's the nurse's role in making medication use safer?
It's huge. We need to work super closely with pharmacists, educate patients thoroughly. What's the med name? Why are they taking it? When? What are the side effects? Advocate for simpler regimens, maybe less expensive generics, and use tools like the Beers criteria or the Stop-He-Start criteria mentioned in Box 14.7.
What are those exactly?
They're basically evidence-based lists that help clinicians identify potentially inappropriate medications for older adults or meds that should be considered but aren't being used. They act as safety checks against polypharmacy risks. Oh, and a crucial point. Avoid the trap of just giving sedatives for confusion. Always look for the underlying cause. First could be infection, could be electrolytes. Sedation often just masks a real problem or makes it worse. And finally, thinking about different care settings. In acute care, hospitals, older adults are at higher risk for bad outcomes. Delirium, dehydration, malnutrition, infections, incontinence, falls. Our interventions are all geared towards preventing these, encouraging family visits, using memory aids, pushing fluids and nutrition, meticulous skincare, fall precautions.
And then restorative care, like home care or long-term care.
There, the focus shifts more to ongoing recovery, managing chronic conditions, really maximizing independence. It's all about collaboration, working with the older adult and their family to help them live as fully and independently as possible.
Wow. Okay, so wrapping up this deep dive. It's so clear that aging isn't just one thing. It's incredibly complex, deeply individual, always changing. And for us, as nurses, understanding all these nuances, busting myths, spotting atypical signs, navigating physical and psychosocial changes, promoting health, ensuring med safety, it's just fundamental. Your knowledge, your compassion, it really can make a world of difference to an older adult's quality of life.
Which leads us perfectly into our final provocative thought for you, the listener. Think about this. How will you take this deeper understanding and actively weave it into your daily practice? How will you move beyond just managing the illness in front of you to truly empowering older adults, helping them thrive, stay engaged, and live well?
That's definitely something to mull over, a really vital question. We sincerely hope this deep dive has armed you with valuable insights and maybe a new perspective on caring for older adults. Thank you so much for joining us, for being part of our learning community here at The Deep Dive. Keep digging, keep learning, keep growing, and keep making that incredible difference in your nursing practice.